Hello everyone, welcome to another session of Next Saviours Essential Question Series for NEET PG 2025. Today we are going to have a discussion on the basic patterns of the ventilators, the basic question that could be asked out of this topic. Now, what is what on ventilator? The first thing is what are the basic ventilator parameters? That means the setting that you can control once you put the patient on ventilator. Now, the first one is obviously the mode. The types of ventilation like VCV, PCV, SIMV. We'll be talking about it in detail. Like this is the area where the modes are given. Here it is the assist control, the volume control assist control mode is on for this particular setting. Then the second one is the fraction of the oxygen given in percentages. Oxygen concentration which is delivered in percentage like 21 to 100% is given. Means in ventilator you can proceed all the way up to 100%. But normally or in ventilator settings, majority of the times it is usually kept in the range of 40 to 60 because 100% of the oxygen, if you give 100% of the oxygen, then it results in the complications related to oxygen poisoning, right? That is why this is the range in which majority of the times it is usually kept. Then the third one is the tidal volume, which you can control or set in the initial settings. It is already, it is the volume of the air per breath, which is around 6 to 8 milliliters per kg. And this is how it has been represented in the ventilator screen. The respiratory rate also you can control. It is the breath per minute, which is set by the ventilator. So around 10 to 20 breath per minute. The PEEP is something which is extremely important because this is the baseline pressure which is responsible for keeping the alveoli open at the end of the expiration. So majority of the times the range is 5 to 10 centimeters of water, but most of the times it is usually kept at around 5 centimeters of water. In some of the conditions it can be increased. This is the baseline of the pressure which is responsible for keeping the alveoli from collapsing or preventing the alveoli from collapsing. And another one is the pressure support in centimeters of water. It is the extra support for a spontaneous breath and the inspiratory time in liters per second. Okay, so this is something which you can control. These are the basic ventilator parameters that you can control. Now, once you set the parameters, then you have to wait for that how the patient is responding. So, what are the measured or the real time the patient data, which are actually the values which are continuously measured by the ventilator, and it helps in assessing the patient's lung function. So one is the peak inspiratory pressure, which is measured in centimeters of water. It is the highest pressure during inspiration, which normally should be within the range of less than 30 centimeters of water. Second is the plateau pressure in centimeters of water. It is the pressure in the alveoli at the end of the inspiration. Now try to understand what is the plateau pressure over here. Like this is the peak inspiratory pressure. After that, the plateau pressure is maintained so that the gaseous exchange can happen at this level. Okay, so this is the plateau pressure. Then the third one is the minute ventilation, which is nothing but it is the tidal volume multiplied by respiratory rate, which comes out to be around 5 to 8 liters per minute. The compliance of the lung is actually the flexibility of the lung, okay, which is measured by the tidal volume divided by the plateau pressure. And normal range is 50 to 100 milliliter per centimeters of water. Now, what is the importance of these plateau pressure, the compliance of the lung? For example, if the pressure in the lungs goes on increasing to an extent that it might lead to a alveolar rupture, okay, like this is the alveoli, and the pressure goes on increasing because of the less compliance of the lung, then in that case you have to maintain the pressure on the lower side. And there comes the importance of the modes in which the ventilator settings are kept, that we'll be talking about later. Airway resistance is the resistance in the airways already you know about, and auto peep is the extra pressure due to the trapping of the air. So these are the measured real-time patient data which are measured by the ventilator, and it helps you in assessment of the patient's lung function. Finally, the waveforms. The waveforms and the loop. In advanced ventilator, the loops are also available, but we'll be talking about that in later. Today we are having a basic discussion on the ventilators. Like, what are these waveforms? One is the pressure time curve. So it shows the pressure changes during inspiration and expiration. Like in this case, Here there is a peak inspiratory pressure achieved during the inspiration. After that there is a decline, and then there is a plateau phase. For that the gaseous changes to be happening, and after that there is a expiration. So this is one cycle against the time curve. Now this end of the, or at the end of the expiration, this graph is not touching the baseline. Why? Because of positive end expiratory pressure, which is kept to prevent the alveoli from getting collapsed. Then is the flow time curve, which helps in detecting the patient's effort. Now, as you can very clearly see over here, that this is the normal flow which is provided by the ventilators of the inspiration and expiration. But imagine if there is a additional curve in between, which means that there are efforts by the patients also. So it can be identified on these flow time curve. And on that basis, you will be deciding that whether to start with the weaning process or not. That means, can we take the patient out of the ventilator or not? And finally is the volume time curve, which displays the volume delivered per breath, which is the tidal volume over here. It is very tightly controlled setting mechanisms. Normally the range is around, or is usually kept less than 500 ml, means near the physiological tidal volume. But in some of the cases where there is poor oxygenation, you can to some extent increase this tidal volume also, or the volume curves also, by external settings. So these are the waveforms which are present on the ventilator screens. Then finally, now we have to start with the ventilators. All of you know about the indication that if the patient cannot oxygenate, if the patient cannot ventilate, if the patient cannot protect the airway, or if the patient is tiring out, that means is getting out of the respiratory effort. In those cases, you have to consider the ventilation. Simple. No one is going to ask you about the basic tables of water, what the indications for the ventilations are. The most important thing related to the ventilators are the modes in the ventilator. These modes in the ventilator, there are two major criteria which will decide that which mode to put on in that particular patient. Now, first criteria is that who is initiating the breath. That means if the patient is absolutely not putting any effort, then what is the mode that has to be selected? Or if the patient is having some effort, then what is the different mode that could be selected in order to provide assistance by the ventilator? That means who is initiating the breath? Is it the ventilator only, or mixed patient plus ventilator, or only the patient? Second is that how the breath has to be delivered, with the fixed volume or with the fixed pressure. Now imagine in case of a condition where the alveoli are too fragile, that means there is a possibility of decreased compliance of the lung. Now in those cases, what will happen? If the pressure goes too high, that it might result in the rupture of the alveoli. In order to prevent this alveoli from getting ruptured, fixed pressure modes are given. But another scenario where the patient is not putting any effort at all, like if the patient is under surgery, some major surgery which is under general anesthesia carried out, so there is absolutely no effort by the patient, then in those cases, fixed volume mode has to be provided so that adequate ventilation is achieved by the ventilator. So on these basis, the ventilator modes are being decided. So one is a volume controlled mode. You know what is volume controlled mode? Only two lines. One is that there is a fixed tidal volume, but the pressure is variable. What does it mean? That in volume controlled ventilation, the ventilator delivers a fixed tidal volume with each breath, but the pressure required to deliver this volume can vary depending upon the lung compliance and airway resistance. It is further divided into two types. One is assist controlled ventilation. That means volume controlled, assist controlled ventilation. Now try to understand what is happening in these cases. The ventilator ensures every breath, whether it is initiated by the patient or by the machine, gets a fixed tidal volume because it is the mode that we have put the patient on. Now, if the patient does not initiate the breath normally, like the patient is in general anesthesia undergoing a surgery, so if the patient does not initiate a breath, the ventilator is responsible for providing one with a fixed volume. But if the patient initiates a breath, the ventilator then still gives a full preset tidal volume. So despite the fact that the patient is breathing or not, we have fixed the tidal volumes. So obviously it is best for those individuals who require full ventilatory support with minimal work required from the patient. That means those patients who cannot breathe adequately on their own, like if the patient is suffering from neuromuscular paralysis or if the patient is in general anesthesia. So in those patients, 100% effort is not there. So 100% the patient is dependent on the ventilators. Now let's talk about it in the form of the example. Now suppose the ventilator is set at 12 breath per minute with a tidal volume of 500 ml. Now if the patient does not breathe at all, because this is the reason why we are putting this patient on the volume controlled mode, they will exactly get 12 breath of 500 ml each per minute. Now, if the patient starts breathing more, suppose there is a spontaneous effort also, say 16 times per minute, then the ventilator will still provide 500 ml per breathe. Now, there in those cases, there will be a risk of overinflation. So if the patient tries to breathe too much, for example, if the patient is coming out of general anesthesia, right? If the patient is getting reversed from general anesthesia, then what will happen? That the patient tries to breathe too much. The ventilator still is giving a full tidal volume each time, which can lead to hyperventilation or even barotrauma. In order to combat with these conditions, the another mode is synchronized intermittent mandatory ventilation, which is also volume controlled. But the key point over here is that the ventilator provides a set number of breath with a fixed tidal volume. But if the patient takes the extra breath, those breaths are not fully supported. They are spontaneous breath without mandatory volume delivery. That means there will be a variation in the volume which is provided by the ventilator. Now try to understand this with an example. Now suppose a ventilator is set to 10 breath per minute with a tidal volume of 500 ml. The patient tries to breathe more. Now the patient is coming out of GA. For example, he takes extra 5 breath per minute. In those cases, what will happen? The ventilator will give 10 mandatory breath of 500 ml, but the patient's 5 extra breath may have only 200 to 300 ml of each tidal volume, depending on their effort. So as you can very clearly see that it usually used in case like when the patient is getting weaned from ventilation. So it allows the patient to start taking their own breath while still receiving some ventilator supports, and it reduces the risk of hyperventilation compared to the fully controlled mode of VCAC. So hope you have understood what are these two volume controlled modes. One is the assist control. So obviously the assist control is providing a full support. So the ventilator gives full volume for every breath, and that is why it is essentially useful for those who are not using their own efforts at all, where the patient's effort is absolutely nil. And the synchronized one is providing a partial support. So the ventilator gives set breath, but the extra breath by the patient are not fully supported. All right. So this is particularly used in case of weaning. Now coming on to another modes like pressure control modes. As I told you in the beginning also, imagine the patient is suffering from some conditions where increasing the pressure or variation in the pressures might result in alveolar ruptures. Like if there is a decreased compliance of the lung, in case of neonates, particularly where the alveoli are too fragile, in those cases, externally you have to control the pressure so that there is no exceeding of the pressure. So the ventilator over here, it delivers fixed pressure, but the tidal volume, it varies. So the ventilator over here delivers breathe with the fixed pressure, but the tidal volume, it varies depending upon the lung compliance. So obviously, what are the benefits over here? It prevents barotrauma. So it is responsible for improving the recruitment of the lungs. And it is particularly useful in cases where there is decreased lung compliance like ARDS, COVID-19, the neonate. Now, these pressure control modes are further divided into two types. One is pressure control assist control. That means full control of the pressure. Here, the ventilator delivers every breath at a set pressure, not a fixed volume. The tidal volume varies it depending upon the stiffness of the lung. So obviously, it is best for the conditions where there is stiff lungs like ARDS or COVID-19 pneumonia, where the volume control may cause high pressures. If I give you one example, like set pressure is 20 centimeters of water, tidal volume may vary from 340 to 440. It is just an example depending upon the compliance of the lung, but the pressure remains the same. So this is the importance of pressure control, assist control modes of the ventilator. Now, what in those cases where too much decrease in the tidal volume might also lead to a hypoventilation? And you also have to take care of those hypoventilations. You have to prevent that hypoventilation from happening. In those cases, you might be requiring some sort of a ventilator where the ventilator adjusts the pressure to deliver the target tidal volume. That means there is no decline in the target tidal volume. So this is achieved by the pressure regulated volume control mode of the ventilator, which is a hybrid mode. So if the compliance decreases, like if there is a stiffness, increasing stiffness of the lung, the ventilator increases the pressure to maintain the volume. Now, if the compliance improves, it reduces the pressure to prevent lung injury. That is why it is called by the name of hybrid mode of the ventilator system. So it is best for both worlds. How? Because it is responsible for maintaining a stable tidal volume and preventing high pressures. So where exactly these conditions means these kind of the modes are used, it is used in the patients with the changing lung conditions. Again, in case of respiratory distress or post-operative cases in particular, where the patient might get improved over a period of time. If I give you one example, like that, you have set the targeted tidal volume to be 500 ml, that this much of the flow has to be given to the patient. The ventilator starts with a pressure of 15 centimeters of water, but if there is increasing lung stiffness and the volume drops, then it increases the pressure to 18 to 20 centimeters of water in order to maintain this 500 ml of the volume provided to the patient. So this is the importance of the hybrid mode. Now, if you try to understand this in one line, like PCAC, this one, it is providing a fixed pressure with a variable volume. But PRVC, it is adjusting the pressure automatically to maintain the set tidal volume. So it is best for the changing lung conditions. I hope you have understood all the four modes over which the ventilator is having a superior hand. But there are some conditions where you have to wean the ventilator out. That means you have to take the patients out of the ventilator. So then the modes would be different. One of the such mode is pressure support ventilation mode, where the minimal help is provided by the ventilators. So how it works? The patient is responsible for initiating all the breaths, but the ventilator, it provides pressure just to support in order to make the breathing process easier. So there is no fixed rate, there is no mandatory breaths. When it is best to be used, weaning before extubation. So for that, pressure support ventilation mode has to be provided, where there is no fixed rate, no mandatory breaths, no volume settings, only the ventilator provides pressure support to make the breathing process easier. That's it. Another one is the continuous positive airway pressure, where no breathes are given, only the pressure is applied externally. So, how it works? It provides continuous pressure to keep the airway open, but the patient must breathe independently. So, it is used in mild respiratory failure or as a final step before extubation, obviously. When obviously it is to be used, like in case of sleep apnea and in case of weaning after ventilatory support. So, these are the indications for the use of CPAP. Another one is BiPAP. And you know why the BiPAP is important? Because, and how is it different from CPAP? Because it provides higher pressure during inhalation and it decreases the pressure during exhalation. That is why it is called as bilevel positive airway pressure ventilation system. So it provides a higher pressure during inhalation, as we have talked about, and it lowers the pressure during the exhalation. So that's how it is responsible for pushing the carbon dioxide out of the lungs. So when it is to be used in case of COPD exacerbation, congestive heart failure with pulmonary edema, now these are the examples. Now one important caution, one important contraindication with these is because it is tubeless, you are not preventing anything from getting aspirated. So it is not used for comatose patient or uncooperative patient because the risk of aspiration is higher. In those cases, endotracheal tube intubation is required, or mechanical ventilation by endotracheal tube ventilation is required. So hope you have understood everything related to the modes. Now we can understand that how the key parameters that you will set in the patient when the patient is uh, kept on ventilators, the and what are the normal values. The first thing is the tidal volume, that is the amount of air per breath that you already know. It has to be kept around 6 to 8 ml per kg body weight. The respiratory rate is breath per minute, which has to be kept around 10 to 20. So these are the initial settings. The fractionated oxygen concentration, so obviously you have to start at 100% and then titrate to the level where the SpO2 comes out to be 92, but it has to be reduced very frequently in order to prevent the lung injury because of over oxygenation. Now P positive and expiratory pressure, which prevents from alveolar collapse, as we have already talked about, is kept around 5 to 8. And today, in case of ventilators, advanced ventilators, this is auto tuned. This thing is auto tuned and it is to be increased in case of conditions where the compliance is low. And pressure support for the extra is for the extra support for the spontaneous breathe. 5 to 10 centimeters of water is the set parameter. So these are the parameters that you have set. Now, in one lines, we will try to understand that how to change the mode based upon how the patient is responding. Because based on what all we have learned, now how will you decide to change the mode? Now, the first one is when. That means what we are going to talk about is that when to switch the ventilator modes once you have started with the key parameters. Once you have set the key parameters, then when to switch the ventilator modes, and you already know about the modes in total. The first one is switch to volume controlled mode when the patient needs full ventilatory support. This is what we have talked about. So it is actually the revision of what we have talked about. When the patient needs full ventilatory support, there is no effort by the patient at all. In those cases, the volume has to be controlled. Another one is a hypoventilation with that low tidal volumes, because in that case you have to keep the volume controlled, assisted control. Okay, so now this thing becomes much easier. Then second point is that when to switch for pressure controlled modes. In pressure controlled mode, it delivers a fixed pressure and the tidal volume it varies. So when should we switch? It is when the lungs are stiff and need lung protective ventilation, where the compliance getting decreased. Okay. The second one is peak inspiratory pressure becomes too high in volume control modes. So in those cases, because the risk of the alveolar rupture becomes higher, so in those cases you have to control the pressure and vary the volume. And finally, if there is a risk of barotrauma or ventilation induced lung injury, right? So in those cases, you have to switch to the pressure control modes. Then when to switch for the synchronized intermittent mandatory ventilation. And it allows a spontaneous breathing between ventilator set breaths. It is just the revision of what we have already talked about. Now tell me where, when, yes, when the weaning is required. So patient is improving and starts to breathe on their own and there is no need of over assistance, then in those cases you have to switch to the SIMV mode. So what are you actually doing? You are reducing the ventilator dependency gradually because of the patient efforts. This is something which is very, very commonly done in the clinical practice. If I give you, if I give you one example, like if there is a post-op patient who is recovering and now breathing spontaneously, but still needs some support, then in those cases, what you have to go for? You have to switch from VCAC mode to the SIMV mode. That's how it is exemplified. Next is when to switch to the pressure support ventilation. That weaning we have already talked about. It is weaning the patient off the ventilator completely. It is the last step before the extubation. When the patient is alert, when the patient is breathing well and take his own breaths, then in those cases, this switching to the pressure support ventilation is required. Now, if I give you one example, like if the patient is with pneumonia, who was on SIMV, the patient with pneumonia was on SIMV, is now breathing on their own with the minimal support, then obviously you have to switch to the pressure support ventilation. The ventilator over here, it only assists the breathe but does not force the ventilation. Hopefully you have understood now, or it makes sense now, because you will be able to identify, you will be able to understand this what we have already talked about. Then when to switch to the CPAP or the BiPAP, or when it is indicated, it is usually indicated in the mild respiratory failure where full mechanical ventilation is absolutely not needed, like in case of COPD exacerbation, in case of sleep apnea. Like, if I give you one example, like if a COPD patient is weaned off the pressure support ventilation and can breathe but still needs some of the support, then in those cases you can go for CPAP or the BiPAP. Remember, the contraindications or the disadvantage or cautions or related to the BiPAPs have been asked multiple times, and it cannot be, or it should not be used in a patient where there is a possibility of aspirations. Now, once we have understood the basic mechanisms of what the modes are, when they are to be utilized, let's see that if the ABGs are deranged, in the sense that what are very, very commonly might be kept in the examination. So, what to do if the oxygen levels are low on the ventilator? The problem over here, like for example, if I say that the ABG report shows that the partial pressure of the oxygen is less than 60 millimeters of Hg, or the SpO2 is declining less than 90%, then it means that the patient is not getting enough oxygen, which can be obviously dangerous. So, how will you fix it? Now, one possibility is that you increase the FiO2, that means the oxygen supply. So FiO2, that means the fraction of the inspired oxygen, is the amount of the oxygen which is given by the ventilator. You already know this. So if oxygen is too low, increase the FiO2. Start at 100% if it is severe, but it has to be reduced to avoid oxygen toxicity immediately. For example, if the SpO2 comes out to be 88 to 90%, then increase the FiO2 from 40 to 60%. But once it is reached 92, then further you have to reduce the fraction of the oxygen provided. Next is in order to prevent the oxygen toxicity. Next possibility is increase the positive and expiratory pressure. The PEEP, it is responsible for keeping the alveoli open. More oxygen can be diffused into the lungs. For example, if PEEP is 5 centimeters of water, so increasing it to 8 to 10 centimeters of water for better lung expansion, it is just through an example which is being provided to you. And the third possibility by which the oxygenation could be improved is to check the tidal volume. Now, if hypoxia is because of low ventilation, then increasing the tidal volume might be of some help, but it has to be increased only if it is required and not by the upper limit. The upper limit is 8 liters per kg, so not beyond this. So these are the three ways by which you can improve the oxygenation. Let's take another example. Like, what if the carbon dioxide levels are too high on the ventilator? For example, if the ABG report shows that the pH values are declining less than 7.30, or the partial pressure of the carbon dioxide is more than 50 millimeters of Hg. Now, in those cases, what is to be done? It means that the patient is not breathing out enough carbon dioxide. That means the patient is suffering from hypoventilation. So in those cases, what is to be done? So how to fix it? One is increasing the tidal volume. The tidal volume is the amount of the air in each breath. So if carbon dioxide is high, increase the tidal volume, which means more air per breath means better ventilation. So increase it by just 1 to 2 ml per kg, but never more than 8 ml per kg to prevent lung injury. Example, if VT is 6, then increase it to 7. It works well if the lungs are normal and they are not too stiff. But another way of doing it, like if the ventilator is set already on the upper limit of the tidal volume, then in those cases, what has to be done? Increase the respiratory rate to remove more carbon dioxide. For example, if the respiratory rate is 12 breath per minute, increase it to 16 to 18 breath per minute. This help blow off more of the carbon dioxide. So these are the two ways by which you can control the excess carbon dioxide in the body. These are just the examples for you. Let's talk about the important concepts related to these changes. Like, do not increase the tidal volume beyond 8 milliliter per kg, as we have already talked about it, because it might cause much, or it might increase the lung stretch, thereby causing the risk of barotrauma. Increasing the respiratory rate too much, that means beyond 30, can cause breathe stacking, that means air trapping, which can be easily identified in the flow diagram or the flow wave patterns. always check if the patient is breathing against the ventilator or not, because in those cases, if you do not want to, or if there are no indication for the weaning, in that case it might require sedation. And the easy rule is that if carbon dioxide is high, then first increase VT if it is safe. But if it is safe to increase, but if it is already running at the upper limit, as most of the time it happens, then increase the respiratory rate. That's it. Let's talk about some sample questions. Like if a 55-year-old male, because these are the kind of the questions which you are getting today in your examinations very commonly. A 55-year-old male with ARDS is on mechanical ventilation with the following setting. They have provided you the volume. The mode is volume control ventilation. Tidal volume is set to 6 milliliters per kg. The PEEP is 5. The FiO2 is 60%. Respiratory rate is 18. And on the ABG, what you are getting is the pH is 7.29. The partial pressure of the carbon dioxide is 55 millimeters of Hg, and the oxygen is 65 millimeters of Hg. Which of the following adjustment would be most appropriate in these settings? So obviously, out of the multiple options provided, the best answer is increasing the respiratory rate. Why? Because the patient has a respiratory acidosis where the pH is 7.29, the partial pressure of the carbon dioxide is on the higher side. So it indicates hypoventilation. So in order to improve the ventilation and remove this excess of the carbon dioxide, we should increase the respiratory rate. We can consider increasing the tidal volumes also, but as you already know that it is running on a upper near upper limit, so it is already at the lung protective settings. So consider increasing the respiratory rate to 24 breaths per minute. Why the other options are not correct? Like if you go with the option A, like increasing PEEP, the increasing PEEP is for oxygenation issues, not for the carbon dioxide clearance. Decreasing the respiratory rate would worsen the carbon dioxide retention. And decreasing the FiO2 is absolutely unnecessary because the partial pressure of the oxygen is still borderline. So the best answer for this is increasing the respiratory rate. Now coming on to the next question, a 70-year-old COPD patient is intubated and is on SIMV mode with the following settings: the tidal volume, the respiratory rate, the FiO2 of 40, PEEP is 5, and the ABG value shows the 7.48 pH, the partial pressure of the carbon dioxide to be 30, and the partial pressure of the oxygen to be 85, which is the most appropriate change in the ventilator settings. So obviously the answer for this question is decrease the respiratory rate to 10 breaths per minute. Why? Because the patient has a respiratory alkalosis where the pH is 7.48, the partial pressure of the carbon dioxide is 30 millimeters of Hg due to hyperventilation. So in order to correct this alkalosis, we should reduce the minute ventilation, which is achieved by the approach by decreasing the respiratory rate to slow the breathing. Why not the other options? The option A, it increasing the tidal volume would further increase the ventilation and worsen the alkalosis. Increasing the respiratory rate would worsen the carbon dioxide washout, and increasing the FiO2 in option number D, increasing the of FiO2 is unnecessary as partial pressure of oxygen is already adequate. Coming on to another example, like a 45-year-old female with pneumonia is intubated and receiving volume controlled ventilation. The ABG report shows the pH of 7.4, partial pressure of the oxygen 58, and partial pressure of the carbon dioxide is 30. Which of the following would be the most appropriate change in the ventilator setting? And the correct answer is increasing the PEEP to 10 centimeters of water. Why? Because the patient has hypoxemia despite having high FiO2. Look at the FiO2, which is 70% provided. Oxygen concentration over here is 58 millimeters of Hg. So it suggests the refractory hypoxemia. So in order to improve the oxygenation, increasing PEEP helps recruit the alveoli and exchange the gas exchange and enhance the gas exchange. So that is why the option A is the best answer. Why not the others? Like decreasing the respiratory rate would not help oxygenation. The option number C, increasing the tidal volume is not the preferred approach in the ARDS like diseases because it might result in overinflation of a decreased compliance lung, and decreased FiO2 to 40% is incorrect as partial pressure of oxygen is still low, right? That is 58 millimeters of Hg. So the best answer is to increase the PEEP to 10 centimeter. That means increasing the PEEP in this particular question. Finally, another example is like a 60-year-old operative patient on volume controlled ventilation with the following settings. What is the next best step if the ABG provided to you is with the partial pressure of oxygen 90 millimeters of Hg and the carbon dioxide is 40 millimeters of Hg? So correct answer obviously is to switch to the pressure controlled ventilation mode. Why? Because the patient has a high peak inspiratory pressure, that means PIP of more than 30 centimeters of water, which it is indicative of the risk of barotrauma. So switching to the pressure controlled ventilation reduces the pressure related lung injury. So increasing the tidal volume, why not? Because it would worsen the high pressure. Decreasing the FiO2 is fine, but it does not address the PIP. And finally, why not increasing the respiratory rate? Because increasing the respiratory rate does not solve the high pressure. So you have to switch this patient to a pressure controlled mode. Hope you have understood everything related to the questions asked. And the final thing that we have to talk about, that when to wean from a mechanical ventilation. Weaning is a process of gradually reducing the ventilatory support so the patient can breathe on their own. It is one of the most critical steps before extubation to prevent the failure and reintubation. So when to start weaning? What is the readiness criteria? So before weaning, ensure the patient meets these criteria. First is the clinical stability. If the underlying disease is improving, like there is a resolving pneumonia, heart failure, respiratory distress syndrome, if the patient is hemodynamically stable without any significant vasopressor support, if the patient requires minimal sedation, that means the patient should be awake and able to protect their airway. Another one is parameters. Like if the partial pressure of the oxygen is more than 60 millimeters of Hg on FiO2 of less than 40%, and the positive end expiratory pressure of less than 5 centimeters of water, it is a good indicative sign for weaning. Second, if the pH is more than 7.3, that means there is no severe respiratory acidosis, it is a good sign for weaning. If the partial pressure of the carbon dioxide is also stable, that means there is no worsening of the hypercapnia, it is also a good sign of weaning. Other signs includes are the adequate respiratory muscle strength, which is identified by the presence of the spontaneous breathing effort, like respiratory rate of 12 to 30 per minute without any excessive efforts. Tidal volume is more than 5 milliliter per kg for the ideal body weight. The negative inspiratory force is less than minus 20 centimeters of water, which indicative of the good respiratory effort. Rapid shallow breathing index, which is calculated as the respiratory rate divided by the tidal volumes in liter. If it is less than 105, lower the RSBI index, better it is for extubation. So less than 60 is ideal for extubation. So these are the protocols, that means when to start weaning. Second is how to start weaning. That means what is the step-by-step approach to wean the patient from the different modes the patient is present on. First is switch to a spontaneous breathing mode. Once the patient is stable and meeting the criteria, then change the ventilatory mode. For example, if the patient is on VCAC or the pressure control assisted control mode, then switch him to the SIMV or directly to the PSV. Why? Because SIMV allows the patient to take their own breath while still receiving some ventilatory assistance. And you already know that the PSV provides minimal support or pressure support to the patient who are breathing spontaneously. Second is spontaneous breathing trials. Once the patient is tolerating the spontaneous breathe, then switch to CPAP or low level pressure ventilatory support. or pressure support ventilation, low level pressure support ventilation, and go for the trial of 30 to 120 minutes. So observe what you have to observe in this trial. Observe for the work of breathing like respiratory rate, heart rate, BP, oxygenation. So if there is no distress, normal vitals, stable ABG, then it means extubate. Second, if the respiratory rate goes on increasing, the SpO2 falls, and the heart rate goes on increasing, there is a swinging of the blood pressure, then and the use of expiratory accessory muscles is also present, it means the weaning process has failed. So, what is the extubation readiness checklist? That means the patient, if has passed the SBT without any distress. Second, if there is a strong cough reflex, that means to prevent aspiration. If there are minimal secretions, and if at all there are secretions, then these are manageable with the suctioning, and the airway protection is intact. That means the patient is alert, he is having a good gag reflex. Then obviously you have to extubate. Now, suction secretions thoroughly, deflate the endotracheal tube, remove the tube when the patient is still coughing to clear any remaining secretion, provide oxygen via nasal cannula or the face mask, and monitor the patient closely for 24 hours for any sign of respiratory failure. So this is how the extubation is performed. And obviously, you should also be aware of when to stop weaning or delay the extubation. That means what are the signs of weaning failure? That if the respiratory rate is still more than 35 for prolonged duration of period, SpO2 is less than 90 on FiO2 of more than 40. The partial pressure of the carbon dioxide is rising with acidosis. The heart rate of more than 140 beats per minute, or if there is swinging of the blood pressure, or if there is a presence of the paradoxical breathing or excessive accessory muscle use. So if any of these occur, return to the ventilatory support and reassess in 24 hours. So hopefully you have understood everything related to what we have already talked about. The question related to the ventilators are the new entry in your examination. So these are the basic things that you should be knowing about, you should be aware of. All the best for your future examinations. In order not to miss any update, please join our Telegram group. The link is provided in the description. Thank you.